Are at the top of the hour. Thank you, Melissa. Start the recording there. And we're going to go ahead and start. Good afternoon and welcome, everyone. Welcome to today's session. My name is Danny Hansler. I'll be your tech producer. We're so glad you could join us for today's important conversation. As you can see on the presentation there, the title is Community, Connection, and Collaboration, a conversation about caring for persons with substance use disorder who are unhoused. Just a quick reminder, this session is sponsored and facilitated by Growth Partners from Hampshire Technical Assistance Center in association with the Foundation for Healthy Communities and the New Hampshire Department of Health and Human Services. We're grateful to these partners for bringing us together today. Before we begin with the session, we just want to go over a few reminders. First of all, a recording notice. I do want to let you know that today's session is being recorded, so others who couldn't be here live. Also, a few Zoom tips, as you can see on the screen, to help the session run smoothly. Please keep yourself muted unless invited to speak or participating. You're welcome to keep your camera on or off, whatever makes you feel more comfortable, but please also avoid sharing personal or confidential information in the chat. Also, we encourage you to use the engagement tools of Zoom. Use the chat to share general comments or relevant sources, or the QA feature if it's available there, or post your question in the chat. And you can also raise a hand if you want to participate. With that, I want to hand it over to our moderator for today, Dan Andrews from the Foundation for Healthy Communities, who will kick us off and introduce our presenters. Dan.
I may take a moment of personal privilege. Today is a heavy day for us at the Foundation for Healthy Communities. Our grants accountant, George DeVoid, is retiring today after almost a decade of incredible service, and we're all missing George. So I want to thank George on behalf of all of us, and I'll be reading directly from the script for once. Today, we're going to learn about some current data and what's happening to efforts relating to ending homelessness and substance use, and then participate in a conversation about how we move forward in this uncertain and challenging care and funding environment. And I'll introduce our participants. Jennifer Chisholm. Before her transition to systems level work, Jennifer was a direct service provider for over 20 years in Manchester, focusing on supporting people experiencing homelessness and those with mental health and substance use concerns. In her last position, she served as the Behavioral Health and Outreach Coordinator for Manchester's Healthcare for the Homeless program, where she oversaw the teams that provided case management, therapeutic and recovery support services in clinic, in encampments, and on the street. She has worked extensively with adolescents, including as a case manager with a transitional living program for young adults aged 18 to 21 who were homeless, and as a clinician in an adolescent substance use disorder treatment program. Since 2016, Jennifer has served as adjunct faculty with the UNH Department of Social Work, where she teaches social work practice and field seminar courses to master's and bachelor's level students. She also provides clinical consultation to a local school district student assistance program employees who work with youth who are at risk of substance use. In her spare time, Jennifer enjoys learning new board games, making gluten-free treats, and watching the joyful chaos served up daily by her 4 cats, Vodka, Baguette, Jalapeno, and Poblano, and her dog, Pamplemousse, the French word for grapefruit. Andrew Warner is a dedicated professional with a strong history of direct service, particularly in the field of overdose prevention with a focus on street outreach. And Andrew has just come to us from a morning at a carceral facility. Currently serving as the Director of Overdose Prevention for the City of Manchester, he supervises outreach staff, manages CDC work plans, and collaborates with various community partners. Previously, Andrew held positions at Better Life Partners, where he focused on business development, training, and community outreach, and at the Doorway at Granite Pathways, where he provided direct services and case management. As a volunteer, he was a founding member of the Queen City Needle Exchange and was the site manager for a year and a half. When Andrew is not doing street outreach or finding new ways to build connection in the community, you will oftentimes find him riding his bicycle, playing his guitar, or hanging out with his small dog, named Sherman. And it's my absolute pleasure to hand the microphone over to Jennifer.
Good morning, everyone. Thank you so much for attending. We're really excited to be able to talk to you about some of the data and some of the best practices. And so let's jump into it. Next slide. I will say, actually, we may get a visit from my cat, Bobka, who loves a good Zoom call. So if you see a little calico going by, that's Bobka. So we're going to start off with some of the data. So the New Hampshire Coalition for Homelessness is probably best known for the State of Homelessness in New Hampshire report, which we put out every year. And so that takes a look at the New Hampshire's homelessness data. And so I will say it's a year behind. So this last report we put out in December of 2024. So it was looking at mostly 2023 data. And so we take a look at two data sources. One is the point in time count, which is count over a 24-hour period in January. So it gives us a snapshot of what's happening kind of on one of the coldest nights of the year. And then we also have the Housing Management Information Systems data, or HMIS. And so that's calendar year data. So that looks at an entire year. So it's a more robust data source, but both have kind of their strengths, and both are unduplicated counts to the best of the ability. And so I also will say that it's important to understand who's being counted, but also who isn't being counted. And so just know that the people in these two counts are people who meet the HUD definition of homelessness, which does not include people who are doubled up in the community. So spending a night on somebody's couch, living with friends or family. So here you can see a graph of the 2019 through 2023 point in time count data. So that's that one night in January. And so the dark blue lines are the most recent, the 2023 data. And so you can see that there was an increase in every population, subpopulation, including overall homelessness. Other than veterans, we saw a 20% drop in veteran homelessness, which is wonderful. So if you go to the next slide. Unfortunately, in 2023, New Hampshire had the highest percentage increase in homelessness in the United States. And so in the United States as a whole, we saw about a 12% increase. In New Hampshire, we saw a 52.1% increase. Some of that had to do, we think, with the number of people who were in emergency rental assistance programs through the state, so that we saw a bump there. But still, the optics aren't great. This is not something that we want to be number one at. So we did see a drop actually in the 2024 numbers of about 8%. So it started to come down. Unfortunately, they just released the 2025 data. And so I haven't been able to fully crunch it yet, but I know that it went up. So we had a big spike, we came down a little bit, and we're headed back up again. So next slide. This is the HMIS data. So they're going to be bigger numbers because it's the year-long data. And so in the HMIS data, we did see an increase across all populations. We think that the increase in veterans in this particular data set is actually because we expanded programs and reduced eligibility requirements for that subpopulation. And so it's actually a good thing because it means not necessarily that we're seeing more veterans who are experiencing homelessness, but that we are inviting more people in and finding more people to serve. So next slide. In 2023, the year-long data showed that we had 6,806 people in total that experienced homelessness in New Hampshire, which was about a 50% increase from over 2020. And so if you look at that, to put it in perspective, if you look at that almost 7,000 people, that's larger than the population of either Plymouth or Meredith. And actually, if you take all of those individuals experiencing homelessness and made them their own municipality within the state, it would be larger than about 80%, just over 80% of our towns. So for New Hampshire, that's like a significant number of people. Next. So next we looked at unsheltered homelessness. So these are people who are staying on the streets in a car, in a tent, in an encampment. And I was super excited when we first looked at the numbers because we saw about a plateau. So there was about a 2% increase from 2022 to 2023, which was, I think, an increase of 7 people. So it's like, okay, like it slowed down. Wonderful. So the preliminary 2024 data was out. So we looked at that just to see if it continued. And if you go to the next slide, unfortunately, it didn't. That trend did not last into 2024, and so we saw a 71.3 increase from 2023 to 2024 in unsheltered homelessness, which means that the number of people who are staying outside in the state of New Hampshire since 2019 has almost quadrupled. So that's where we're at. HMIS data did not plateau. So this is the year-long data of people who were staying outside in 2023. And so we saw a 60% increase there. So, as you can probably guess, I'm sure that a lot of you might be renters. And so the math just does not add up in the housing economy and the wage economy in New Hampshire. So if you go to the next slide, New Hampshire Housing puts out a rental report every year. And so this is some data from them. And so in 2024, the median two-bedroom rent in New Hampshire was just over $1,800. And so HED says in order to be able to afford that rent, you need to be paying 30% or less of your income. And so in order to afford that two-bedroom apartment, a household would have to make $73,300 a year. But if you look at the median renter household wage in New Hampshire, there's almost a $20,000 a year discrepancy. So again, the math just doesn't add up. And if you were to make minimum wage in the state of New Hampshire, you would have to work 194 hours a week in order to make that apartment affordable. And so if you click to the next slide, the problem with that is that there's actually only 168 hours in a week. So you would literally have to clone yourself. Next slide. So next, I pulled some data just about mental health and substance use disorder within the home population of people experiencing homelessness in New Hampshire. So these numbers are self-report numbers. And so we have seen an increase both in people reporting mental health conditions and substance use disorders. And so in 2024, the number of people who were reporting that they had a mental health disorder was about 40% of people experiencing homelessness in the point in time count, while about 30% of people were saying that they had a substance use disorder. So next slide. All right, I'll pass it over to Andrew.
You're muted, Andrew. Oh.
It never gets old. So we started our project here in Manchester in 2023. We got a grant from the CDC for a $300,000 check to fill the position of director of overdose prevention and to set up a team that could do outreach. But the data you can see right. We got going right in 2023, and you can see there wasn't a big drop that year in calls for overdose, but there was a big drop in fatalities. And then you can see in 2024 we saw over 100 drops in calls for overdose, more than that. And then we're on track now for this year to be, about half of what we were doing in 2023. So 2 years in a row of pretty great numbers. And you can see in Nashua in those same times, they did see some drops too, but they did not see the amount of drop that we experienced in Manchester. And there's a lot of different variables for that, but one of them was that we did get our outreach team going, bring out Narcan to the community, things like that. So yeah, you can see the data in action when we started the project and we got going, and then you can see, the drop in Manchester, pretty substantial, and then in Nashua, you can see a more average drop that was going along with the numbers from our national numbers. Excellent. Next slide. And these are the numbers that I'm really interested in. The calls for overdose aren't as compelling to me. A lot of the calls for overdose end up not being calls for overdose. They end up being people sleeping in their car, taking a nap on a bench, things like that. But these are the actual fatalities, and so to see our numbers from 79 in 2022 down to 58 in 2023, and that was a direct result of us having an outreach team that's giving out Narcan. It's a direct result of our police, getting tougher in certain areas, having more outreach workers in the community. I mean, there's a bunch of things. This is not just from my team doing anything. This is a citywide response and collaboration to make this happen. But these are the numbers that we're the most, proud of, is these drops in fatalities. And you can see they're still going. So, our worst year ever, 2016, we had 90, and right now we're on track for 28 if things keep going the way they are, and so that's massive. But over the last 3 years, we can see that, being out in the community and focusing on these things can lead to actual. I never thought that there was going to be data like this at all. I was thinking if I got, a 10% drop, that would be some kind of miracle, and to see it year after year, it's been pretty amazing. Next slide. And these are some of the other, this data you can really see. I like this because it actually shows the years by the month. So we started tracking this with our software in 2020. We plugged in all of our data, and you can kind of slide down the months. So in January, 2020, 2021, you can see that little spike. But then from 2023, where we started this real specific intervention with getting Narcan into the community and doing outreach and focusing with data, and the first responders on board with the health department outreach workers on board with the Manchester mental health outreach workers and the family and transition health workers all working together. Through this collaboration, you can see how all of our months pretty much just get lower and lower every year, So I like this graph because it just shows you can just keep going down and see how every month we're on track for less. And that is the direct result of our city really getting involved in this and getting worried about it and making some changes. And I think that really started in just making a place to collaborate and have conversations about what's going on and having meetings about it and making it important. Next slide. Yeah, so this was, I think I maybe got ahead of myself. But yeah, this role was created by this grant from the CDC. We're one of 20 cities that received this grant of $300,000, and we're able to write a work plan along with the CDC helping us to collaborate with these other 20 cities across the country. And it is really interesting because in that collaboration, we're able to see where Manchester was kind of falling in with building an overdose response, and so we were years ahead of some of the cities, and then we were maybe a couple of years behind some of the other cities. But it was really interesting just to see where our community awareness and preparedness around overdose, where it fell along these other cities that were very much like us in size and kind of socioeconomic. But yeah, so we were able to not only start my position, Director of Overdose Prevention, but I was able to do a work plan for the city around, I hate to say it, but the low-hanging fruit of, where can we make the biggest differences, the quickest. And with the CDC kind of helping us with that work plan, and then the work that we've all been doing, in Manchester for years, we're able to put together a work plan that really was based around overdose prevention. So if there was a fatality spike that happened, if there was a bad batch of drugs that were on the streets in Manchester, there would be a team. There's no one in place to respond to that. So we built a team of people that would be able to respond at a moment's notice and go out into the field and let people that are using drugs on the streets know that there's a spike going on and that's a very dangerous time to be using drugs, and give out Narcan and give ideas about options. And there'd also be someone that could spread the word with our community partners, so letting our shelters and our treatment programs and other community partners know that there's an unsafe event happening with drug use in the city. And so that was the one thing that we could get everybody on board with, is that there should be a team that could do that. And so I hired a team of people. You can see a photo of them there being recognized with the mayor. But I hired a team of folks that were already working in the community Almost all of them have lived experience or lived experience with a family member with substance use disorder. Most of them have had experiences with being unhoused, mental health issues, things like that. So they're all peer support folks that already had relationships with the folks that we're really trying to focus on. So my team was made up of people that were working at the Doorway, Families and Transition, and Manchester Mental Health, and all of our community partners, so that we would have a robust team that could go out and model what recovery looks like. Obviously, be able to respond if there was a fatality spike. But then there's all these other things we could be doing also, which is morning and evening outreach. So one of the things I noticed is that all of our services are 9 to 5 Monday through Friday, and so we need some early morning and late evening outreach for those folks that don't work on 9 to 5. So we started going out in the community with my team, bringing harm reduction supplies and Narcan into the community where people are hanging out, and then obviously offering hand washing supplies and waters and snacks and all the harm reduction stuff. But also, I would say the most important thing is the cheerleading aspect and the community aspect and the support aspect. So I'm out on the streets doing outreach or at the needle exchange or doing something on the streets with my team Monday, Tuesday, Wednesday, Thursday, and Friday. And so our folks on the streets of Manchester are, unfortunately or fortunately, depending on who you might ask, seeing me and my team up to 5 times a week. And they might see me with different folks that have different roles. Some of them are case managers. Some of them are, one of them is a peer support person. One of them is a nurse practitioner. So we all have our different wheelhouses. One of them is a specialist at getting people in the treatment. But we also have our stories and our lived experience. And I would say that support network that we're giving people of that continual cheerleading and support and refocusing, and sometimes just listening to really sad stories, for long periods of time and giving out water. I would say that is what was really brought the data and made the data look good, is I think that connection and that ability we have to be in front of people up to 5 times a week. And so along with the outreach team, we also did some other things where I'm working in the Valley Street Jail, where we really saw a lot of just people really stuck in that loop of arrested for small amounts of drugs, spending short amount of time there, not getting much treatment, and then being back out on the street. So I've been doing recovery support groups in there now for a couple of years and offering people access to recovery support and also different ideas for when they leave versus just being stuck in that cycle. Yeah, so that's what we've kind of been up to. The great news is in all of that, we have also had a really good effect on, the number one priority, which is saving lives, and this was a collaborative experiment I'd seen go well in other cities. I'd seen other cities that had more of a collaborative approach with everybody. I'd seen how that works well in Lowell and in Worcester, in Portland, Maine. And so I thought maybe Manchester could kind of do that. And out of that, we've seen data that actually follows that says that making a space for collaboration and support and really making a really great outreach team that can be really active in the community can lead to less calls for overdose and less fatalities. And I also, another thing on a side note is, I think a lot of this is also about supporting the outreach workers. So when we're out doing outreach, we're also supporting each other, and there isn't really a place for that in our continuum of anything. There's a small amount of outreach workers, and we tend to get burned out really quickly and no longer do outreach. And so we have to really support each other also, and so in doing outreach and driving around together and supporting our community, we also support each other in, the very nuanced challenging things that we deal with on a daily basis, being an outreach worker in Manchester. And I also always have to mention that at the end of the day, we do this out of love, we do this out of love for our community and for our neighbor and for people that are struggling with, substance use disorder and mental health and the unhoused issue. And we do believe, the ROAR team believes that by showing people love and compassion and decency and respect in the community, that we're going to have better outcomes for our community. And miraculously, we actually have data to prove that also. So that very rarely aligns. Next slide. Yep. So this is, some of the things that we'd seen for our objectives, to respond in real time to the community of people who use drugs when an overdose spike occurs. So, like I said, having the ROAR team ready to go and on call 24/7 to make sure that if there was a spike, that we'd be able to do that. Getting Narcan to folks that are using drugs, obviously, that is a challenging thing for a lot of our communities. And we have a unique situation in Manchester where we do have access to our homeless people a little bit easier than other communities where they're more marginalized. So I think it was easier for us to affect the overdose rates quickly because I was able to just pump Narcan into the community of people that were actively using drugs easier than I think other communities could. And a lot of times that was done sheerly through me giving out my harm reduction supplies and saying, if you're getting harm reduction supplies, you're also taking Narcan. I don't really care if you want it or not, you're taking it. Because there's going to be a point where you don't have it and you're going to need it and you're going to wish you did. And so I'm telling you, you're taking it now, and just the ability to interface with the highest risk population, so people that are unhoused and people that are leaving incarceration, to interface with them and make sure that they actually have Narcan on them, that they know how to use it, that we've dispelled all of the rumors and hearsay about how Narcan works in the community, so they have real data around the drugs that they're using and how to respond properly. And so by doing that, and having direct access to them, we're able to bring down the fatalities. The one part I haven't talked about yet, we've also been involved with the Community Response Unit, which is a unit of the Manchester Police. So I've been working on this project since we started it 4 years ago, I think, 4.5 years ago. We started the post-overdose response program with Manchester Police. I was working at Better Life Partners at this point, but I did it as a volunteer. And we're going out into the community and finding people that have recently overdosed and offering them Narcan and also just a peer support person that could try to help talk to them about, maybe if they want to go treatment or some other options besides using. So using the police in a way where it was actually helpful, they knew a lot about our folks. They knew a lot about some of their habits and where they hang out and where they hide out. And there was a bunch of Manchester police that were also really interested in changing the outcomes for our community. And they were tired of arresting people over and over. And, the community response unit police usually are more senior police that have realized that they're definitely not going to arrest their way out of this problem. And they wanted our folks to see that there's a portion of Manchester police that care about them and want them to see them get help, and so I was really nervous about taking on that role as someone who also runs the needle exchange, and people were nervous about me possibly being a police officer or what have you. But I just saw the opportunity to work with the police and show our folks in the streets of Manchester that there are police that are actually really worried about them and want to see them do well. So that was really exciting. So we were trying to find them with the police. Support or improve data sharing and surveillance to inform overdose prevention and response efforts. That's something that we did with some software that we have just to show the mapping of where overdoses are actually happening. The police hired a bunch of data analysts to actually take that data and put it into a program that actually maps it out for us and shows us the times of day, and allows us to really get an idea of where things are happening. And that allows me and my team to go out and pay attention to certain areas. And, as the pressure in Manchester is changed on the unhoused folks with police presence and things like that, we have seen with our maps how the overdose areas have changed and gone from more centralized, safer areas to respond to an overdose to areas that are a lot more challenging to respond to. But once again, using the data and using all of our community partners and trying to collaborate and break down these siloed, barriers between programs, I think that's where the gold is. And then obviously using the data and any computer software.
It is.
My
bad.
Trainings. So one of the things I do a lot of is harm reduction and overdose prevention trainings. So what that looks like is I go to all the new hire training for families in transition and for Farnham Center. I also do on Wednesdays, we do a Knock for Narcan program with New Hampshire Harm Reduction Coalition, where we actually stand out on Elm Street during lunch hour rush, so 12 to 2, and we really try to find and talk to people that don't do drugs and don't talk to community partners and don't go to the shelter or the community agencies. And we try to give them Narcan kits. And then we talk to them about the realities of Narcan, how to use it, the realities of the drug supply in the Manchester area. And I think that's one of the greatest ways we can really move the needle on this stigma and just misunderstanding and wives' tales that we've heard and ridiculous, fallacies we've heard handed down from generation to generation, is just have real conversations with people on the street about really what's going on. And we get one of two things, like, we don't care about that, or how can I help, and then we kind of have conversations after that. So, that's something that no one is doing in the community. And I think it's really important just to break down, this miscommunication about how to respond to an overdose. And, if you live in America in 2025, you should probably have Narcan on you and know how to use it. And then the last thing that we did, and it's actually very important, especially where everybody's getting this opiate abatement funds, is we're getting all these opiate abatement funds, and everybody has a bunch of ideas about what to do with that money. And some of those ideas are great, and some of them are not. So we actually wrote a strategic plan for the city, how to spend that money in a way that would make a lot of sense, so that we do have a game plan for what we're going to do with the opiate abatement funds, and how do we get our entire municipality on the same page around harm reduction and overdose prevention. So tons of work to do on that still, but we are working and plugging away. Next slide. Awesome. And this just shows some of I think the power of, the street outreach portion. We can build programs and buildings and fantastic, ways of getting people transportation. But at the end of the day, there is a population that's never going to go to that building and they're never going to do the thing, and so the overdose response team intervention, being out in the community, you can see, how many people we're contacting, how many kits we're able to give out, how many conversations around recovery happen. And this is just 6 hours a week for a year. This is just 6 hours a week for a year. This is the data I collected. So imagine if we had a team that was going out for, I don't know, 40 hours a week or something like that, what we could do and how many points of contact we could have, and how many interventions could be done of sending people to treatment. Like I said, a lot of times it's just motivational interviewing our folks to hear what it is that we can help them with, but if you're not there to do that motivational interviewing, usually our folks are kind of sitting there with a bunch of things they want to work on. But I think one of our goals is to kind of keep our folks on track of like, good morning, how's it going? What's happening? Oh, last night was wild. Yeah, the rainstorm. Like, I hope you guys are okay. I heard you're working on getting down to get your foot looked. I know we talked about that yesterday, and your foot's not doing good, but like, are you going down there today? Because I needed those people to say that to me sometimes too, so that's one of the things I think is the most important thing we do is really just that keeping people on track daily. Sending, linkages to care, using my phone is a huge thing. Just having access to a phone, being able to have access to an address that people can send things to, giving out, the supplies we get. There's no dinner in Manchester. So there's no meal in Manchester for dinner. So there's a lunch 5 days a week if you're allowed in that building. If not, you don't get that lunch. And then there's no dinner. So surprisingly or not surprisingly, I would say one of the biggest things people ask me for is just food and water. There isn't a place to get water that's good potable water for our folks. They don't have things to carry around in, and there's no meals. So shifting from even a harm reduction lens to a more just water, food, socks, hand washing supplies, foot washing supplies, very basic things, ponchos, sunscreen, stuff to wash your hands, so you can clean your hands, things like that. We are kind of shifting, from the harm reduction lens so much to that other, all those other options that we can give out. Because quite honestly, that's something that has been missed, I think. We assume that people have socks and lunch and stuff like that, and I'm trying to get them into treatment or make sure that they're, using Suboxone and not fentanyl, but I think we forget about some of the other things we can do. But yeah, these are just this is a really brief, snapshot of some of the stuff that we offer, and then some of the, encounters we're able to have because we were out doing street outreach.
Okay, so facilitators, what time do we have? When are we going to start the Q&A, just so I can check the time and figure out where to go for slides, just to make sure.
So at this point, we still have 20 minutes to go. I don't know how you want to split that time available.
Okay, great.
We do have one question in the chat, though. I don't know if you want to address it now.
Actually, we have a Q&A set aside at 12:50.
Oh,
12:50. Okay. So that, I think the question was about the community fridge model and whether or not that was being used at all.
Correct.
Andrew, yeah. So Andrew, can you speak to that?
I don't know what it is, so no.
I think kind of like a sort of like free little library. I've seen communities where they've had free fridges. I don't know of any that are being used in Manchester, or any like community pantries where people put things out. I haven't seen any, but it's a great model. So let me talk a little bit about encampment disruptions. And so people may know that in June of June 2024, I have a typo on my slide, the Supreme Court just made a decision that it allows municipalities to either criminalize or to fine people who are sleeping or camping on public land, even when emergency shelter is not available to them. And so New Hampshire jumped on that. We actually have the first municipality in the nation that made changes to its ordinance based on that ruling. Right after the ruling happened, it was within 2 business days. So actually a National Criminal Justice Journal reached out to the coalition to interview us about that. So it's a real challenge. So people don't have a place to, they're, staying on public land because they don't have a place to stay, and then there's no place to go. So if you go to the next slide, the coalition took a look and did a lit review to see what the research says about those disruptions. So next slide, please. There we go. So as people can probably imagine, it increases all kinds of mental health and physical problems, anxiety, depression, stress. It really disconnects people, and so the isolation increases, which also increases hopelessness and despondency. And they've also found that it increases both mental health crises and a risk of violence for people, while at the same time decreasing people's connection not only to mental health services, also to physical health services, so to their health home, and recovery support as well. And there's also sort of a loss of physical items. So you get disrupted, you can't carry everything with you. And so then you have to get your supplies again. So next slide, please.
It also makes it insanely impossible for anyone who's trying to do outreach or support.
Yeah, and so you'll see this quote here in the middle of the little New Hampshire piece. So people are told to move and ask, where do we go? There's no answer to give them. So that was actually a quote from a police officer at a roundtable that we did in New Hampshire. And so I have a lot of empathy for law enforcement as well, because they are in a position where they're enforcing the laws and also do not have the resources to answer that question when people are asking, well, what are we supposed to do? And so like it says here, connections to care are just disintegrated. And so you can see on the right-hand side, these are from a series of interviews that we did with homeless service providers in New Hampshire and outreach providers. That the disruptions are just leading to a total lack of trust, because people just fear that they're going to get moved along. If somebody knows where I am, even if it's a formally trusted service provider, that information is going to get leaked, and we're just going to have to move again. And so that just totally disrupts the continuity of care, whether it be for trying to get people housed, or whether it's trying to get them into a treatment center. Right. So next slide, please. And we've really seen the effects. And so this is some data from Andrew about the location of overdoses, as he was talking about, and that they've dispersed over time. And so, we have these repeated encampment disruptions. So people spread out and they really lay low. They get disconnected from their providers. And then the prevention efforts are really, there's barriers to that, right? And so the overdose locations aren't as predictable. So I don't know, Andrew, if there was more to say about this slide in particular.
It's hard to see without knowing the map, but you can see there's some of these larger circles here, like in the center of the map. You can see these kind of larger ones. So there used to be a couple of areas where people were located, where we had our overdoses, and everybody around there had Narcan available, and it was basically a safe space to use drugs. And then the police started breaking up some of those areas and putting pressure on them. And so it used to be in the center of our map, there was a couple locations that had the majority of our overdoses, and they were happening in places that were a safer place for people to overdose. You can see this map, it's almost like they're very evenly spaced just completely across the map. And this shows how people are just using drugs in these really chance places where they can just use this one time. It was happening a lot outside of buildings, in front of buildings, and you can just see how they're really spaced out in a way where they're not centralized at all. And that is from the safe places where people were being broken up, just like a camp.
Next slide. So just really quickly, so from the macro lens, from the systems lens, I'll say that there are evidence-based approaches to working with people in encampments and encampments themselves. So if you're doing work at the systems level, there's two resources I would suggest. So one is from the U.S. Interagency Council on Homelessness, the 19 strategies, which I'll talk about in a second on the next slide. But National Alliance to End Homelessness also has a really great set of interim strategies. So we know that the long-term answer is housing. That takes a long time to develop and to build. And so there are people experiencing homelessness right now that need services now. And so the National Alliance put out some guidance around that. And so with the 19 strategies, it's actually been officially adopted as a guiding document by not only the New Hampshire Council on Housing Stability, which brings together state leaders to sort of figure out the best approaches for New Hampshire in addressing housing and homelessness. And then all three New Hampshire continuums of care, which bring together homeless service providers across the state. So, but we need, I think, to just be increasingly promoting all of these strategies so that municipalities are using them and understanding that they are best practice and will be effective. So on the next slide, here's a summary of the 19 strategies. And so in the sort of weird, like green, light green, yellow color that for some reason I picked, I highlighted the pieces where the health system really intersects with this. And as a matter of fact, if you look under collaboration, number 4, empower outreach teams and health providers to lead the effort. So really health systems are a key player in working with people in encampments and people who are experienced unsheltered homelessness. There are other places too, just around prevention, crisis response, and just the equity. And so being able to address the really unique needs of people with chronic and acute health conditions. The research shows actually that people who are experiencing unsheltered homelessness start to show signs and symptoms of diseases and other disorders that housed people show in their 70s. People experiencing homelessness start to show in their 50s. And so the mortality is a lot younger as well. So next slide. So Andrew will talk a little bit about some strategies from the overdose response team. Oh, you're muted.
Yeah, so one of the things we started early on in outreach in general was trying to build places where people felt safe to go, and then hanging out in places where people are going to, versus trying to chase them all around the city and bushwhack looking for people. Outreach work is slow as it is to begin with, and then it's much slower. So what I found was going to the places, having a needle exchange Tuesday and Thursday where everybody's going to that exchange, and then bring services to that exchange, or build a care fair at our engagement center where we have everybody that anyone could want to meet with and have them there. And then you can tell all the outreach workers can tell everybody, go to the engagement center on Thursdays, but we have a care fair there, and anyone that you need to see is there. And then I go to that and I hang out there. So finding, instead of trying to find people, it's more about finding places where our folks are already hanging out and then being there, or creating spaces where our folks feel safe being and giving them incentive to be there, and then finding them there. Obviously, any kind of targeting outreach, so around, like I said, the data maps that we have, or any of the collaboration, we have a meeting every Wednesday with the city where all of our city partners get together and we talk about a list of issues around unhoused folks. And we go over that list, and we're working on this list, and we're collaborating and sharing information every day, really. So that's super important. Continuous assessment of specific regions' needs. Now we're in that stage where we've put some systems in place, and we have some systems that have been going for a long time that are really getting up to speed. And now we're really just trying to tweak those things to make them even more effective. And so, like, one way I found out doing that is I go to Valley Street Jail to do recovery support groups. And I have a list of everybody that's at Valley Street, and then there's another list that the police have of people that have overdosed that we've tried to find. So if I can cross-reference those two databases, then that's going to help me to find people at Valley Street Jail that have previously overdosed that I can talk to that might be interested in recovery support. So right now we're in that place where we kind of put some broad systems into place, and now we're really trying to tweak it. And harm reduction as a foundation of the work, obviously, we have to build systems where people can't burn bridges, because our folks burn bridges and then they don't access services. So I'm not saying every single service needs to get to the point where no one burns bridges, but we have to have services in place that are pretty fireproof, and so harm reduction, being, meeting people where they're at, no matter where, and allowing them to access services, and always giving them a fresh start every day is just the utmost of importance. Like I said with the Valley Street Jail recovery, going in there And like today I found a guy in one of our recovery groups that I've been looking for a year, and now he's in Valley Street. And I said, "Hey, I was looking for you when you were overdosing last summer. I didn't know if you were going to make it. I didn't know where you were." And he was like, "Yeah, I'm here now, you know." And so now I can go in there and do recovery support with him. But I was looking for him on the community response unit, and now I have him in Valley Street. I can go in there and do recovery support. Next slide. So I mean, one of the things I've always I don't have to pay the bills in any of my programs, so I don't spend any time worrying about money. You know, and I feel like that is a cavalier attitude. But you know, I've been doing this work now for 10 years. We've had a bunch of different types of presidents, and we've had some pandemics, and we've had a bunch of different changes and things. And I think that by doing the right thing for the individual, no matter what, is the lens we have to use. You know, keeping it about their needs and constantly checking in with them and not assuming that I know the needs of an unhoused person that's doing fentanyl in 2025, because I've been housed now for 15 years, you know, so I have to constantly be checking in with people to make sure that we're offering something that they need. Using data to drive your needs, it's the only way you're going to keep your funding going, improve anything, is getting data. You know, outreach without data is a hallucination. Diversify, impact, and expand your wheelhouse. When I wrote the work plan for the city in collaboration with the CDC and the health department, we were really looking to build a system that would be recession proof. You know, and there's a lot of opinions about harm reduction. And what I tried to do is build a program that no matter what changes came down the pipe, that everybody could say, we need someone to pick up needles and we need someone to go to the jail and do recovery support. And so I was hoping it'd be recession proof. And then, you know, all of this happens through connections and the relationships that we have. So, you know, this program was built on getting people from all these different programs together to work together at one time. And it's been successful. You know, public stigma and the one-on-one conversations that we have, you know, are super, super important. There's still a bunch of people out there that think Narcan is just enabling people to use drugs. And we need to make sure that at some point those people understand that that's not the case. Next slide.
Yeah, so I think that we can stop here for the Q&A, but you can look in the slide deck because I'm assuming it's going to be sent out. I did put in a couple of decision-making tools. We are in some really uncertain times, bumping up against some ethical, you know, questions. So I put in Frederick Reamer's ethical decision-making framework for people. If you're making a tough decision about programming or policies, internal policies, and then there's a decisional balance in the next slide. So we would love to hear what questions people have.
If I could just unmute for a moment, I neglected at the top of the hour to give some well-earned credit to the New Hampshire Bureau of Drug and Alcohol Services, represented so well today by Courtney Voracek. They are the people who fund this work and so much else and do a magnificent job of providing coordination and support, and just wanted to make sure that they were acknowledged. And I'll mute again.
I believe if we switch to the next slide, so I saw in the chat that they were somebody was looking for contact information. Yep.
And then Andy, we have some chat questions that came in.
Yes, we do. We had a comment on the community fridge model. I don't know if you want to address that. The fridges and pantries are strategically placed in various locations, which allows residents to donate and or take food. Is there any additional information? And there's also an additional question. Are there any specific challenges when engaging or providing services to racial or ethnic minority groups?
I will say that according to our report, like that homelessness itself, people of racial and ethnic minorities are overrepresented in the homeless population in New Hampshire. So if you're somebody who is African American, Black or African American, then you're 4 times more likely to experience homelessness. If you are somebody who's Hispanic or Latinx, then it's double. And we have some, from another equity standpoint, we have data that's showing that LGBTQIA populations are also overrepresented. So absolutely.
Thank you. And also Andrew already replied to a question there in chat regarding real-time data on overdoses.
Yeah, I don't know what the software is called, but I can try to find out from the Manchester Police Department. They're the ones that put that together.
Great, thank you. We still have a couple minutes if you want to post a question or come off mute, and also you can directly ask. If not, as mentioned there by Melissa, thank you. We are sharing the contact information for both our presenters.
Ready to close it out? Oh, evaluations.
I have a question, actually. Is that okay, Dan? Do we have just a minute?
We have 4 minutes,
Okay,
so you're
great.
good.
Is that okay if I ask a question? Okay, great. Jennifer, what do you attribute to that jump in New Hampshire being 52.1% increase, which is the highest increase in homelessness in the country? What are you attributing that jump to?
Sure. So I would say in part, we recognize that people are being counted that joined the ERAP program. So that emergency rental assistance program kind of did bump up the numbers. We don't know exactly to sort of what extent, but that covers a portion of it. But the other thing is just that it's becoming harder and harder and harder since COVID to be able to afford an apartment. And so, I have somebody in my personal life who is a single mom who, has a kiddo, 14-year-old, and had to move recently. And so she has a master's degree. She's a professional with a career, and she's spending over 50% of her income to rent every month. The average spending for 2 kids under 5, if you don't have subsidized childcare in New Hampshire, is $32,000 a year. Life is just really hard to afford. And we are so under inventoried on housing in general, never mind affordable housing in New Hampshire, that, as I said earlier, just the math isn't adding up. So I literally, when I was working for Healthcare for the Homeless, had clients who had increases in their rent anywhere between $300 to $700 a month, and one just boom hit. And so if you're already spending 50% of your income to rent, like $300 is really hard to swallow. Never mind, the top end of that we were seeing.
As a follow-up to that, though, is there a population migration happening in New Hampshire from other states that are causing the housing stock to not be available?
I see. So that's a really great question. There was some talk, some news articles, et cetera, when COVID hit, that people were trying to get out of cities. And so that I think that we did see a bump in people kind of moving here. I don't know if that's sustained. We've been under inventoried for housing since before that. There's a lot of talk, especially in sort of North Country or more rural/touristy areas, about the Airbnb market as well. Sort of that short-term rental market being a challenge. I know legislatively we've made a lot of progress this year, according to Housing Action New Hampshire, one of our partners, around some of the regulation stuff that will make it easier to build more inventory. Again, I'd just also like to say that that's going to take a long time. So we need to make sure that we have other interim supports for people who are homeless right now. Yeah. And I'll note just really quickly, one of the things that the coalition is looking at is the need for medical respite in the state. So that's that place where people who are experiencing homelessness can go if they don't meet medical criteria to be inpatient in a hospital, but can't take care of themselves, or, are need more care than a shelter can give. And so it's a real passion of mine to try and explore that for New Hampshire, because we're the only state in New England that doesn't have a medical respite program. And we're only one of 10 states in the entire country that doesn't have that. So stay tuned for more information, because again, at our roundtables that we did, that was just a huge need that was spoken about across the state. Because hospital discharge is really tough. I, have a lot of empathy for hospital social workers trying to figure out where to place people that don't meet the inpatient criteria.
Thank you. Incredible presentation. I knew it would be when we met on the Friday afternoon in Manchester in January. And thank you so much for illuminating some of the places where we are working and offering some incredibly substantive technical information and just the care that we hope that we are all committed to providing. And I'm just so pleased, and thank you, Jennifer and Andrew, and I'm so grateful for your work.
Thank you.
Great. Thank you, Dan. And thank you all for joining us today on this session, this conversation about caring for persons with substance use disorders who are unhoused. A special thank you, as Dan mentioned, to our presenters, Andrew from the City of Manchester and Jennifer from the Coalition to End Homelessness, for sharing their time, insight, spending the time with us. Before we wrap up, we want to mention a few quick reminders. You can explore additional resources. Also view today's session recording once available, and watch past COP sessions in our website, nhtac.org. Also want to mention that our next meeting will take place on August 21st from 12 to 1 p.m. and we hope you'll join us again. If you haven't already, we encourage you to join the COP community to stay informed about future sessions and share tools in this website. And also, finally, if you're attending for the CEU credit, please make sure to stay through the full session, as you did already, and complete the evaluation. We're going to put the link here in the chat. Melissa, thank you for that. Be sure to include your name in the evaluation to receive your certificate. You can also scan the QR code on the screen or follow the link, whichever is easier. Thanks again for being with us today. We look forward to seeing you in a future session. Take care and enjoy.